So the BTK inhibition is definitely one of the two pillars of the treatment of patients with chronic lymphocytic leukemia. On one side, BTK inhibitors, as mentioned. On the other side, the BCL2 inhibitors. And the BTK inhibitors have proven to be so effective that indeed there's been really a race to find new molecules that could be more effective, safer, compared to the first in class that has been ibrutinib. A number of molecules, acalabrutinib and zanubrutinib in particular, have been developed as a second-generation BTK inhibitors. We have seen the results of the head-to-head comparison with ibrutinib at EHA, and they may suggest that indeed the second-generation BTK inhibitors are safer. They have a better tolerability profile compared to ibrutinib, in particular because both molecules, zanubrutinib and acalabrutinib, showed a lower frequency of atrial fibrillation and cardiovascular toxicity in general. Maybe there is a potential for increased efficacy, as hinted by zanubrutinib in the Alpine study with the head-to-head comparison. But of course, there we need a longer follow-up, having only 15 months of follow-up so far. And then we have a third generation of BTK inhibitors that it's completely different from the first generation in terms of biochemical structure of the drugs, and indeed they bind in a different portion of the molecule, and in particular they are reversible inhibitors compared to the first and second generation inhibitors. And so these molecules, and in particular the LOXO305, but also the molecule by Arcule, showed efficacy in patients with chronic lymphocytic leukemia, but in particular those relapsing and refractory to ibrutinib or other BTK inhibitors. Really suggesting that by changing somehow the way how the drug interacts with the BTK molecule, we may indeed increase the efficacy, and therefore we can also think of sequencing these drugs after the first and second generation inhibitor, so to prolong overall the response to the same class of drug before switching a patient to another class of drug. So I think the path was already bright, meaning that we really witnessed a lot of advancement in the treatment of patients with chronic lymphocytic leukemia, thanks to the BTK inhibition. But the future looks even brighter because we will have more molecules. We can choose the best for each of our patients based on their comorbidity profile, on their genetic profile, but also it will help really to maintain the patient under this type of treatment for a longer time.